you got to reach.
I know, right?
Okay, we're live.
All right, here we go.
We had a rock. Yeah, we're live. 6 o'clock Central, 4 Pacific, and what's Thursday morning by Santiago.
That's right.
Singapore?
Yeah. Singapore time, 7 a.m. Thursday morning.
We had a pretty rocking show last week. Got a lot of comments on it. So we need a referee.
Really?
Oh, yeah.
I would sell for a moderator, but okay.
Oh, what moderator? Need a better moderator. You go to the bar and you chat. You talk, and if you're louder, that means you're more right.
Oh, I wasn't talking about that. I was talking about what was going on the sidelines between our audience.
Well, we connect people, whether it's a good thing or not, because the show is for informational and entertainment purposes only. Joy, please check with your primary care physician first.
I guess it matters about whether you have a license or not, Pete, because having a license can put you into some liability in situations like that. So that would be my advice.
Should I add to the disclaimer? What else can I say?
Well, the big thing is that we can't host that kind of a discussion because it does have the appearance of our approval.
Oh, well, we don't approve.
Right, but
okay.
I didn't used to worry about any of this stuff until a friend of mine got taken to court very unpleasantly by a very cranky doctor for practicing medicine without a license because she told a person how much zinc to take after surgery. So
look, Radar says no one's ever sued a neurofeedback.
Oh, that's not true.
Oh, they've tried.
There's been plenty of suits. Yeah. Was it Ohio that for a while the Ohio Board of Medicine was trying to say that neurofeedback was exclusively the purview of medicine, and they were taking this grad student who was getting her hours in social work, I think, finished off, if I'm remembering correctly, or maybe junior psychologist, and she was finishing off, and they
slammed her to the wall.
But she ended up being victorious. It just took a lot of time and effort.
Right.
So, eventually was it Ohio? It was Ohio, wasn't it?
Iowa, I believe.
Iowa. There's Iowa. 4 little letters, just not the same.
Right.
Yeah. So there are litigious and psychologists, who do neurofeedback get sued occasionally. So it's a thing. It's a thing. Yeah.
Happy birthday
there he is.
to Jay once again. Missed you, buddy.
What was it?
3/4 mark of the century.
Yeah. As my brother said, I'm entering my 4th quarter.
That's right. You're 3/4 full.
He's a year older than I am, so he's got it scouted out already.
So are you still recovering from the festivities?
It was a 3-day marathon, and my normal level of activity is this. So it was a lot, but it was a fabulous time. I enjoyed it immensely, and I got a lot of contact with a lot of people I normally see only online. So it was fun. We played hard and had good science, and that makes for a good meeting.
Who got the good raffle stuff?
It got scattered around. A lot of people got stuff. I didn't track it. There was a few bobbleheads. I think we found 12 bobbleheads laying around.
Not just laying around; they were carefully procured for the raffle.
And I think Renita's still squirreled away a few more. So we've still got I think 6 or 7 of them in boxes, and I have the original without the logo on the pocket. That was just a prototype, basically. So I've got the original prototype, but then I guess that's me too. So
yeah.
Well,
as long as you got the gold one, Jay. When you left, man, we derailed. Oh my goodness, we need a better moderator.
Weren't you saying that was the good feedback on that episode, or did I mishear that?
Oh, look. As long as you get feedback, life is all about feedback. Okay, so we're trying to keep it in the rails here, and Joy's letting me know about the licensing and all that, and hopefully nobody's going to take my MBA away.
Well, we have to be aware of what we're doing and not. Not. This isn't to provide specific advice to individuals, just to discuss topics and and that can be helpful for individuals who have questions, but it's not that we're handing out prescriptions or.
No, because you always got to check with your primary care physician first, Jay, for entertainment and informational purposes only. That'll carry me forever, Joy, I promise you.
Well, one thing, Pete, I will tell you, just FYI,
Hit me.
checking with your primary care physician will tell you 9 times out of 10, what? That garbage? That's bunk. It doesn't work. Don't waste your money. So, or they know nothing about it. They never heard of it before. So it might not be the source we want to send them to.
Hey,
I got some good news. Good news. There are more and more primary care physicians, etc., that not only are learning about this, but know about this. So I'm going to stay positive. But unfortunately, Joy, that was what we were dealing with a while. But like just continuing on that rant, I've no issue whatsoever with a good skeptic. But a good skeptic is open to research, is open to looking at the evidence, is open to reading the articles, et cetera, et cetera. So, yeah. Now, on the other side, why don't we just go through that there are a lot of individuals who call themselves, quote unquote, neurotherapists who do not know what they're doing. And yes, for these individuals, it doesn't work. So, it's an unregulated term or terminology with a lot of unregulated equipment. So anybody seeking services has to do their due diligence, and anybody recommending neurotherapy services, so primary care physicians, also have to do their due diligence.
Yeah.
Aren't you happy?
And if you're referring to a primary care physician, you also have to remember half of the doctors were in the bottom half of their class. So, you can't just refer blindly to any profession. So it's not like
feeling really nasty today.
No, that's not nasty.
We're feeling pugilistic this morning.
Due diligence has to be done for physicians and psychologists and neurofeedback, for techs, whatever. Speaking of techs, Santiago, you've just flown from the U.S. all the way back home. Are you okay?
I'm getting there. It's taking a little while, but I'm getting there. I'm going to be careful about what I say because I don't want to blur out anything dumb because my brain is not all the way there. But I'll have to say this, though. I did a training in Romania before I went to the summit, and we had 82 people at that workshop, out of which we had 6 neurologists and 6 psychiatrists and about 4 neurosurgeons. So the medical field is becoming more and more interested in what we're doing. Yeah. I see the momentum going in our favor, at least worldwide. I've been to a few countries teaching, and more we're going to see more medical professionals involved in this and interested in this, trying to stay away or at least not rely on medication alone. I'll be in December. I'm going to be doing a 1-day pre-conference workshop for a psychiatry, Asian psychiatry conference in Bali. And when they called me, they initially asked me to speak for 2 hours, then they switched it to 4 hours, and now they want me to do a full day on neuromarkers, EEG neuromarkers for neuropsychiatric conditions. And the invitation came from a psychiatrist in Indonesia, who's a good friend of mine now, where I've done some teaching before. So at least on this side of the world, I see the tide turning, and I think that's really, really positive. Now, the lady who does the trainings in Romania, she's the distributor for iMedicine, the Korean system. But what she's done is she's developed a system in which the person who's interested in doing the workshop has to sign a contract, which was designed by a lawyer. So when they sign this contract, first of all, she doesn't sell the helmet or do the trainings for people who do not have a medical license or a health-related field license.
Yeah.
Number two, the person buying the helmet is by law bound to take the workshop and do monthly supervisions. And number three, they cannot claim to cure or claim that they can treat conditions that they're not licensed to do, that go beyond the scope of the practice. And so I think that's positive, because at least in some places, people are being more careful about how we go about working with neurofeedback and neuromodulation.
You mean somebody's doing it right?
Say again, please. Sorry.
I said, you mean somebody's doing it right?
Yes.
So Santiago, Jay, you guys were all in Suisun City enjoying the west winds. What was the vibe there?
That's Sassoon City. So, but
that's what I said.
One of these years.
Hey, he still can't pronounce my name. You want him to get your city right?
You guys are dialectators. Come to Chicago. We're gonna make fun of the way you guys talk.
Exactly.
But what was the vibe in Suisun? Like, what were people talking about when you had a break and everybody's talking? You know, like what's hot? What's going on?
Well, the meeting was basically heavy on biomarker discussions and medication prediction based on biomarkers and neurofeedback protocols driven by them. Yuri Kropotov talked about biomarkers and ERPs. He had two separate talks, one in general about ERPs and one about PTSD more specifically. And, Antonio Martins-Moro spoke from London using ICA component analysis, not for de-artifacting, but for identifying meaningful components and using those components to guide training. Anyway, it was, I think, a fairly deep dive into biomarkers, and Giancarlo Licata was trying to get more specific with our language about biomarkers, neuromarkers, biomarkers, phenotypes. You know, the language is all kind of sloppily transposable, but he's looking for a little bit more specificity, and I can agree with that. It's just a difficulty getting everybody to come to a common agreement on anything, you know. So.
Becky's got a question. Anthony, you got that?
I was one sec.
Here, I got it. Rebecca Basham, I missed you, girl. I want to see some more of those pictures. Can you please comment? Can you please comment on Villanueva's presentation?
Michael had a discussion where he was a little bit upset about the state of some of the field being kind of getting together and being happy about ourselves and being a little sub-scientific. But they finished with some really solid neuroscience, and Makoto finished with some fascinating work. You know, at the level of the thalamus, you have a reticular nucleus of the thalamus, which is a generalized nuclear body that produces acetylcholine and allows the other nuclear bodies to be rhythmic, but it's not usually identified as a thing. It's driven by the non-specific as opposed to the specific nuclear body's projections, and this diffuse projection ends up being a feature that ends up being identifiable as a different entity within event-related synchronization, desynchronization. If you present a high-frequency series of pulses, you get an initial low-frequency burst, in the wavelets, but the high frequency is a frequency following of the stimulus, and that's the specific projection. And on the onset and offset, detecting the start and also detecting the stop is the reticular nucleus, and they've got some very, very nice data. And so it's nice to see some basic science and the use of high-level analysis as well. I mean, wavelet analysis up into the gamma range isn't done all that often in the neurofeedback world, but wavelets are becoming more and more common. The Sense AI platform was all based on wavelets. They got my bad free advice many years ago, and their engineer actually looked at the wavelets and thought that they behaved extremely well, allowing them to differentiate EMG and gamma. So they were quite tickled about that. Anyway, the higher level analysis, and I agree that some of our meetings do, even the Sassoon Summit is largely very, very social, and we have to get past that to get to the neuroscience.
Anthony, what's going on in your chat room, man? First of all, you got any more hurricanes? You over that?
Well, they're tracking one, but I don't know. Maybe we'll.
Yeah, that
maybe
doesn't
we'll
look
fine.
good.
It's beginning to say that, I've literally seen articles saying that the flow of people to Florida may be coming to an end based on the high insurance costs. I've seen figures like doubling is common. So that's basically, what's going on down here, at least.
Going back to the alligator.
Yeah.
Don't feel left out in the cold out there. State Farm just canceled 70,000 fire insurance policies here, home insurance policies here in the U.S. Here in California, I mean.
Yes.
And they're in places like Santa Cruz and up in the Sierras. If you live in the woods, you're not going to get your home insured anymore. So. Their insurance companies are looking at climate change risk increases, and fires and floods and hurricanes and so forth are that risk.
That's terrible. Flipping topics real quick, I've so far at the Sassoon conference, I listened to Jessica, I can't pronounce her last name.
Yor,
and she had a startling fact that I thought you guys might find interesting. I looked it up as soon as she said it, and sure enough, there's a lot of citations. She said that as many as between 40 and 50% of autistic adults report experiences of sexual abuse during childhood. And I think she tied this in with the fact that it's hard to know what symptoms that we associate with autism actually may be more correlated with PTSD. So I thought that was kind of startling. I don't know if
autism can be a cause of PTSD. Their childhood, their life is different and offers challenges that they have no way of understanding constantly, every moment of every day. If the vast majority of autistic individuals have some degree or another of sensory integration difficulties, and when you do not perceive the world accurately, Santiago was learning about that. The fact of the matter is that you are challenged on a minute-to-minute basis, and you find out that you're wrong constantly. You get up and you walk out of the room, and instead you walk into the door jamb. How did I do that? I saw it there, right? A particular bumper on your car is always bashed in. Why? I mean, why are you always hitting that bumper instead of any of the others?
Well, and not only that, it's also the way people treat you. And, and that's one point I really loved about Jessica's presentation is I really learned a lot about how sometimes as a clinician, my own misconceptions get me to treat autistic people differently. And that brought a very important sensitive point. And I also like the fact that what you're saying, Joe, is very important, is why we need to stay away from the label and look at the EEG to look for the comorbidities and look for the tendencies. It's very important. And I mean, one thing that I really loved about the conference was everybody was about the neuromarkers and focusing on what we see in the EEG and staying away from labeling people and diagnosing people, just throwing names for things and focusing about what's happening in the brain and how that relates to how people feel. And Jessica brought that along. Penny Jean's talk was very interesting too. And I love how she's integrating the photobiomodulation into it. And how we're more and more educating people into that. And I think this particular forum, this Q&A is very important for that. It's not for us to tell people, specifically what to do, but to talk to a professional who's going to help you understand why things are happening. And I think that's the education that we need to do. And that's at least what I try to do when I go teach. I tell them, look, just focus on looking at the patterns and stay away from the labels. And more and more try to deviate from the DSM-5 model alone, to have more compassion for people and to also do more ethical and responsible service.
Yeah, I'm going to get strung up by my registry here, but because a lot of psychologists are in the business of labeling, but I think it's one of the largest disservices we can give. Unless there's a really, really specific intent and purpose to it. It pigeonholes us. It puts blinders on us once you have that label. Obviously we're all talking about the EEG, of course, look at the biomarkers, but also the symptoms, and not if they're listed or not listed in that lovely little book that all of us love, the quote unquote DSM. But I also want to loop back to what Anthony said. Unfortunately, that statistic is across oh my gosh, bad me, that's my telephone. You did not witness this. Okay, it's off. No, we've seen this in individuals that have any type of developmental delay or cognitive delay as well. The instance of sexual victimization, I don't know, I hate to use these negative words as well, but the likelihood that people are going to be taken advantage of, and unfortunately, specifically in a sexual way, is horrendous. And we need our radar up here. I don't know what else to say. It's just that they're tragic statistics in terms of the ugly people out there taking advantage of individuals. With any type of different processing, emotional processing.
Yeah, and the effect of adverse childhood experiences are starting to be well known. The very negative impact on later life health consequences and everything. So tragic. It's a statistic that is shocking, but when you actually have people in a conference take the ACEs score, the percentage of them that have an ACEs score of 4 or more is actually fairly high, and you can expect long-term negative health consequence with that level of experience if there isn't a specific intervention. And that's the trick with these. If there's a specific intervention, you can turn around the long-term negative health consequence. And I think the tools to make that turnaround are in the hands of the folks that are working with applied psychophysiology.
Is that ACE questionnaire given out? Do all the clinicians use it as part of intake, or anybody want to guess on a percentage?
I wouldn't have any idea about that.
Yeah,
I think that the percentage of therapists who are actually trauma informed is very low in my experience. I don't think that it's something that is common practice. I do use it, and I do ask for trauma.
It's a very popular term now, though, unfortunately. And in my region, again, you're seeing workshopped, and everybody's saying they're trauma informed. Again, I don't want to go too negative here, but there's trauma informed and there's trauma informed. And also what is a trauma and what is not a trauma. We get really kind of caught in definitions. I talk about big T trauma and little t trauma, how trauma is culturally defined. And also, I mean, we talk about gender, we talk about the life cycle. What one individual perceives as a trauma from one lens versus what one person perceives from another lens. We have to be really, really careful. And that, of course, is where the EEG comes in. Alpha blunting, everybody, okay? But the other thing about that is it doesn't tell you whether you've been through a trauma. It tells you whether you successfully processed a trauma. Jane Santiago, was there not a talk on markers of trauma as well as Susan? Or did I misread that?
Not specifically that I remember, no.
Mm-hmm.
I mean, Yuri Kropotov talked about the therapies for PTSD, yes. So, yeah.
Okay.
And the neurophysiology.
Yeah. Mm-hmm. Yeah. But I mean, the other thing is, in terms of, we also don't want to over pathologize. If you look at, a lot of people are very familiar with sex trade workers and history of sexual abuse. And, this is the four legs cats type of analogy. Again, everybody's kind of familiar with it. I'd like to repeat it because it's kind of funny and fun, but, all cats have four legs doesn't mean all animals with four legs are cats. But you will find that the majority of females who find themselves in the sex working trade do have a history of sexual abuse. But there are many, many individuals who have thriving careers and good family life, et cetera, that also have horrendous histories of sexual abuse. And I think our job as clinicians is to parse out, what are the I don't want to say survivor factors, but what are the differentiators that permit people to go above and beyond the negative or horrendous life experiences they've had, and what are who are the individuals where this is the beginning of a negative trajectory. And I think that's also part of being trauma informed, and it's also a part of being able to identify situations of trauma while they're happening or before they happen, etc. So, I was talking about lenses. I think we really, really need to get a broader lens on things.
Yeah. And also
one of the very positive things that came out of the meeting was Greg Charbonneau's presentation. He was looking at a biomarker for gastrointestinal pain or pain, and Greg has gone through. He's a neuropsychologist, and normally neuropsychologists don't do treatment; they do testing. They're paper and pencil testing to come up with a diagnosis. And when he started doing EEG, QEEG, he thought it was an interesting add-on. But now, because the insurance companies are looking at the diagnosis as not being that valuable anymore, the neuropsychologist getting authorized to do testing is having difficulty. So actually having an abnormal EEG, QEEG ends up leveraging the neuropsych testing that they then get authorized.
Hey, can I put a shameless plug in here in terms of the cost of a neuropsych and how many neurotherapy treatments you can do for the same cost? And the cost of a neuropsych just gives you a bloody label again. You don't do anything with it. Okay.
Thank you.
So
thank you.
Greg, as a neuropsychologist, is licensed in Washington State. He's a center of excellence for the state. But the neuropsychology board thought that the EEG QEEG was not appropriate for neuropsychology, and they challenged his license. Much to their disappointment, after 3 years of litigation, he won.
Good.
The neuropsychologist, if you can show your competence, you have to demonstrate competence with any technique, regardless of what it is. But if you can show competence, a neuropsychologist now can do EEG, QEEG if it's done appropriately. And the neuropsychologist on the board that had the bug about the EEG, QEEG was thrown off the board. that cost them $160,000 to pay back his lawyer and $50-something thousand to pay him for his time. So they fired her off the board. So it's kind of shifted the tone of what you can do in Washington State as a neuropsychologist. You can now do EEG, QEEG without having the licensing board breathing down your neck. So we can all thank him for breaking the, I don't know, it's not a glass ceiling, but I don't know, broke the electrode tether. I don't know what.
Anthony, what's Triona asking? Is I never heard of alpha blunting.
This goes back to Mari's comment. Triona asked, "Can you circle back to alpha blunting and explain that more?" I guess if Mari wants to start, and others.
Essentially, and again, I know we want to be really careful about diagnosing, et cetera, and we want to be really careful about talking about protocols. But one of the things that you do want to look for is in the occipital region, from an eyes open to an eyes closed condition and back to an eyes open condition, is how healthy your alpha is in terms of whether it jumps down and jumps up and comes back down, the speed at which it does so, et cetera, and that can tell you a lot if you're qualified to read it in terms of unprocessed trauma. And again, the devil is in the detail here. That's why I don't want to go in. I mean, I literally lecture 1 hour on alpha. Jay, I think you lecture for 3 days, and Santiago, maybe you do for 5, right? Yeah. So please don't run with this. But alpha can tell us so much in terms of processing, and there's no coincidence that we're talking about the occipital lobes and visualization, etc. A lot of the work goes back actually to the area of the Vietnam vets, and the theory is that alpha shuts down to protect individuals who have been through very severe trauma from flashbacks.
There was a statement on the little comments underneath that said QEG is not covered by insurance, and that's not correct.
No.
Digital analysis of the EEG is covered if the EEG has been done, but you have to get the EEG recorded and interpreted. The digital analysis is what they call it. They don't call it a QEG, and that's covered by insurance, as is the interpretation of it. So if it's done appropriately with appropriate credentials, every bit of that is billable.
It's usually more covered
than four billing codes.
It's more covered than neurofeedback is, in my experience.
Yeah.
It's more readily reimbursed than neurofeedback.
But the credentials can make or break it.
Yeah. If you're not credentialed to read the EEG, how are you going to get a QEG? So that there's a little gatekeeping thing going on with that. I think there's in the ECNS, the EEG and Clinical Neuroscience Society, they do coursework there, and they have a testing body that's affiliated with them. It's not the same exact body. I can't remember their acronym, but they do provide board certification as an electroencephalographer for medical doctors. But I don't know when they started, maybe a decade ago, providing electroencephalography credentials for PhDs. Now, Barry Sturman, when they said they were going to do that, said, "Oh, I'm going to go right in and get my electroencephalography credential," and I said, "Oh, very, 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 don't run in and take that test right now, because it's not the test you think it might be. The doctors that are going in there are taking that same test. Can you tell me what PAFA is? That's a standard acronym, periodic anterior fast activity." He had no idea about that. How about PLEDS, PLEDS, periodic lateralized epileptiform discharges? I mean, if you don't know those kind of just knee-jerk acronyms, you're not going to float going through this test. So take some of their coursework before you go jumping in to take the exam. But just because you've got a background with some kinds of EEG doesn't mean you know clinical EEG. And if you're going to be certified as an electroencephalographer, you're going to have to know the EEG medically and clinically. So it's not
Which
an
isn't a
easier
bad idea.
exam. It's not an easier exam, but it is available to PhDs who want to become, seriously credentialed, and it's not an easy exam. John Hughes used to teach that course.
Well, I mean, quite frankly, most exams at the PhD level are not easy. They're gatekeepers, and I mean, I can get into even from the primary school level all the way up to a postdoc. We do have an issue in terms of our exams testing the information you need to function out in the real world in your profession, or are they testing the capacity to take a test, right? I mean, we can go all over the place there. But I do want to loop back once again, some really, really good news in terms of, again, if you have certain credentials, you can dictate what is an assessment, okay? So, you can call our little ADHD checklist an assessment and bill for assessment, or an EEG. If you get information, you can assess information from the EEG, that can be billed as an assessment. You have the discretion on that in many regions if you have the credentialing. So again, it really depends on who you're working with, who you're mentoring with, what is the purpose of what you're doing, et cetera, et cetera. So the codes, et cetera, in the States are great, but I think we have to look with broader lenses. And I think you will find that there are ways to help people and help them get their insurance that they dearly, dearly pay for to cover it.
So, Mari, maybe our differences are, I mean, here in the U.S., obviously, no matter what you're doing an assessment for, you're doing it for something, right? You're assessing for prescribing medications. You're assessing for neurofeedback. At this moment in time, there is no such thing as a code for doing an assessment for preparing for neurofeedback. Now, we might consider we don't
preparing for neurofeedback. You can do an assessment to rule in or rule out the cause of certain symptoms. It's a semantic game.
Mostly it is not semanticing when it comes down to codes. I mean, I only know that because I've spent
I'm only a Canadian up north here, but
I've spent 8 years dealing with the AMA CPT code panel. So it was one of the ones that we've been supposed to be working on, but kind of got
and insurance companies, once they found that they paid you a huge amount of money, sometimes they come and audit. And if you give them any reason to deny the coverage that they've already paid you for, they're going to ask for the money back. There was a practitioner in Southern California. He had over $1 million of insurance payments to him for ADD, ADHD treatments. And they came to his office and they took him to court, trying to get over that $1 million back, basically. Luckily, he had tape recorded with their permission the instructions on how to bill from the insurance agent directly from the company, and he had followed that, and he won. They ended up paying him a small fortune for having taken him to court as well. So.
I think also a very important point here to our listeners is, speaking of the subject of assessment, is the specificity that QEEG brings to the equation, which that some of the other tests do not bring to the table for you. I've had this experience in my career a few times in which I do a QEEG for somebody and I go through the interpretation. And sometimes people tell me, you're not telling me anything new. I already knew this. But what I tell them is, well, do you know that this was coming from this part of the brain and then we can address it this way? Oh, well, no. Okay, go. Sometimes the parents go, well, the jury's out there and we're on the fence about neurofeedback. We're going to try something different. And 9 out of 10 times these people would come back to do neurofeedback because the medication alone didn't work, because the psychotherapy alone didn't work. Or sometimes, in most cases, in children or teenagers, they would have done something that worries the parents now, to the point that they want to give the neurofeedback a try. And when they came back, I would always ask the question, what happened? Yeah. And they would say, what do you mean? I said, well, I wasn't born yesterday. What did he do? Well, yeah, he tried to burn down the school. I'm exaggerating, but it would be something that would really throw the parents into action. And then we would do the neurofeedback and they would get better. And guess what? From QEEG to QEEG, you see the change. It's the specificity. And so it's the specificity and the insight that this can bring, because this can help you, this can help address many things. And again, trying to stay away from being too specific, but, medication, nutrition, inflammation, it can help derive other forms of intervention that sometimes written tests cannot bring into the equation. I mean, Dr. Hill talks about this all the time with the nutritional approaches that you can sometimes derive out of a QEEG. You can, help orient the person into how they can help their brain through proper eating, through supplements, through exercise, through sleep. And that's not a level of specificity that we can get out of many other types of testing. I think that's very important for the listeners out there who are still on the fence about QEEG, brain map, and neurofeedback.
Something else I've seen QEEGs do that nothing else can do is completely shut up an entire team of school practitioners, whether social worker, principal, assistant principal. It shuts them down immediately. If you let them explain all of their tests to you and all of their procedures to you and why this child is such a pain, and then you go, oh, it takes all of 5 minutes to explain the basics of looking at these colorful maps. And if you can explain, like you said, Santiago, exactly, well, this part of the brain really represents the auditory processing department. And I know you're talking about how bad their memory is, but I'm wondering what they think they're remembering, because if they processed it wrong, what they were hearing, they're not going to remember what you think they're. And I have done this time and time again, where the parents are throwing their hands up. We don't know what to deal with the school. The school is unhappy. We don't know what to do to make them happy. I'm like, call a meeting. I'll go with you. We'll sit there. We'll explain it to them. And without exception, I think I don't go in with an adversarial view. I'm going for helping. The teachers all are very defensive in the beginning. And at the end, they're thanking me because now they have better ways to offer accommodations and things that are far more specific and useful to the individual student. None of them are there to make people miserable. They're there to help, but they get frustrated when their helping motions don't help. So if we can say, if this is the area of the brain that is having a trouble, we're working on that with neurofeedback, but you guys are going to have to help along for a while. And it's just how receptive they are to that.
Yeah, the beauty of this, and I'm backing Joy 100% here, is you're not just telling them what, you're telling them why. Okay. And for the child as well, like, why am I acting this way? Most kids don't enjoy getting in trouble. They don't enjoy not having friends. They don't enjoy not being able to pass a test, et cetera, et cetera. So the ability to tell them why, and then of course, how you can help. That doesn't involve a pill that can alter personality, et cetera, and appetite, right?
We have all these courses online.
I'm just stupid. I have a bad brain. I have a bad brain. Yeah. Constant, right?
Today I did 12 QEEG reviews, and 3 of them were people that had ADHD diagnoses and did not have any ADHD in their brain and had auditory processing issues instead. And the way that I see that is what you're describing, the auditory cortex, but I also always do a CPT alongside it. And I can tease apart auditory versus visual in the CPT that I use, the executive function testing. So in all 3 cases, I'm like, wow, you're above average. What's the hole in your auditory processing and your performance? Oh, look at your brain. It's also there. So that's my neuroscientist putting behavior and performance in contrast to find that stuff. So I would argue that the brain maps are super useful and find things and specific things that you can't otherwise see, but they're best used in contrast with assessed performance, not necessarily history. I'm a big fan of no history, blind EEGs, but I know that for the clinicians in the room, that sounds horrific, but putting things in contrast, performance and physiology is super important to then not just believe data for its own sake, is my My big takeaway.
Can you get insurance to pay you if you don't have a?
I do. I mean, I don't have a medical. No, I have I'm a scientist. I'm an educator. I teach people to become their own experts. I don't treat.
I mean, I don't want 5-0 to come down on everybody because they do. Blue Cross will come and get you. They'll say, "Give me the records for the last."
I don't get paid, Pete. The way that I do it is people pay, and then I
Yeah.
write a super bill up, and I don't put a diagnosis on it, and I don't put a doctor's thing on it. And their doctor does. Their therapist does. Their therapist works with me to fill out the rest of the super bill if they have any reimbursement potential. But even with their insurance company saying it's going to get some reimbursement potential, the actual reimbursement tends to be pretty poor. And they, routinely get denied the first time or second time they send information.
Well, you have all these courses out.
Is anybody interested in why the reimbursement level is so low?
Yes.
There's a real reason for it.
Why?
So back in 1998, when we got the first codes, the 90901, those ones, it was expected. The gentleman is Bob Whitehouse from AAPB. He did all the work back then to get those codes. He came back to AAPB and said, guys, there was way more work than I thought it was going to be, way too time consuming. But the next step is you have to go to the committee that puts a value to each procedure. So you get to say, how much electricity do you use? How many cotton balls do you use? How many electrodes? What is the expense? What's your office rate? What's your equipment rate? What's your every single penny that would go into what the cost of a session is? And that gets submitted to this committee, and they come away and say, oh, okay. So the value for this particular procedure is X number of dollars. And that is where the ground has to start for the insurance companies. No one ever went.
How about Becca here then? Maybe someone can help me with the codes. Would I be able to submit for billing if I have them signed off by a neurologist?
Yeah, absolutely.
Rebecca, contact my business partner, Ali. He does the billing. There's 4 simple codes, 2 technical codes, and 2 professional codes. EEG, interpretation, digital analysis, and interpretation. He can give you the numbers. I did the medical end of it. He does the business end of it, so I don't know the codes off the top of my head. But they're routine. And if you work with Rusty, he knows them as well. So
that could have been a $1,500 course right there.
See how nice everyone is here.
We minded our P's and Q's because of last week.
And
what happened last week?
Rebecca saw my business partner Ali at the dinner party, so it's not like they haven't met.
Very cool. At Sassoon, I was listening again Jessica's presentation. I've listened to a few, but that one's on my mind. She said, I had a patient with subclinical epileptic discharges, and I was told to refer to neurology. And immediately when she said, I said, that's not good. And sure enough, she came right back and she said, well, I didn't know this doctor, and they said nothing was wrong. And unfortunately, at that point, the family lost confidence in me. Yeah. And I think it happened again in the same presentation. So I just wanted to bring that up because I hear occasionally neurofeedback practitioners will say, oh yeah, refer to neurology or whatever. And then they don't say what's supposed to happen after that. And I think Jessica even said, or it was somebody that said in regards to said, well, I like to coach the family. Ideally, the practitioner, but I also like to coach the family. We may not hear back from them, but I just want to check. So I wanted to throw that at you guys.
Sure. Again, half of the doctors are in the bottom half of their class. So take that, set it aside. Neurologists have on the average 6 months of specialized training. That's not much. Yeah. If you've been focused on EEG as a specialization for only 6 months, you don't really have a background in it yet. An electroencephalographer or epileptologist has 1.5 years or more of specialized training. If you're going, and quite often neurologists don't really think much of EEG. If you show them an abnormal EEG, really they'll say, we don't treat the EEG, we treat the patient. And unless the patient's having a seizure, they're likely not to prescribe. And it's a shame. 85% of the time, people that have a psychiatric diagnosis with no history of seizure, that have epileptiform content in the EEG, get better psychiatrically when treated with an anticonvulsant, which would be denied by that neurologist. Psychiatry is not limited by the
But a
same.
lot of those neurologists cannot look at an EEG
Yeah.
and see epileptiform discharge.
Yeah.
And so there's this,
Yeah.
there's this perspective of neurologists saying, well, why we bother doing an EEG to capture your epilepsy? Because most of the time when we do EEGs, we don't see seizures. So they're not that useful. It's really common to have a seizure disorder, get an EEG, and see no seizures, see no epilepsy.
Yuri and I were teaching together in Australia, and it came to his. I taught for a couple of days on EEG and QEEG. It comes to ERP for his couple of days, and they started out with a recording. And the people that were there in Australia in 2009 were primarily psychiatrists and neurologists in the audience. It wasn't a lot of neurofeedback practitioners at that point. The person who took the ERP test was a neurologist. And I stepped out, I looked at my phone, caught up on my email and whatnot, came back, and I'd seen too many 20-minute sitting, clicking on a mouse recordings done. So I came back in when they were cleaning up the data. And I look, step back, look, left frontally, there's an epileptiform discharge. And the neurologist said, I'm surprised anybody saw that. First of all, I'm not going to see it? Give me a break. Of course I saw it. And he said, but it's meaningless. Well, that's interesting. A neurologist who's got an epileptiform discharge, and he still thinks it means nothing. Now, he just did a CPT task. Superior performance. Well, he's a neurologist. He should do pretty well, don't you think? 2 omission errors, no commission errors, good reaction time, good variability. The 2 omissions he had were when the 2 discharges happened. Now, you tell me they're meaningless now. After you just took this test, aced everything but the 2 times the discharge happened, and that's when you had those little brain farts or whatever you think they were. These are not meaningless discharges. They mean something. You just didn't see what they meant. You were having a little absence period during the discharge and didn't respond to the stimuli. Now tell me they're meaningless again. He was a person of color. He kind of went gray because he suddenly realized, I have little absence spells. He thought they were meaningless, and now he has to reassess that he actually has a form of epilepsy he didn't really give any credence to.
It's a really sad situation, I think, in terms of disciplines and lack of cross-pollination. When we talk about neurologists and what we think their scope of practice is versus what their scope of practice actually is. And again, I can throw psychologists under the bus, in terms of what our scope of practice could be, and many individuals who just do assessment. And that's the case in a lot of disciplines. And I want to really give a shout out, obviously, everybody on this panel, but, beyond, please, help your clients to understand what scope of practice is. And just because you have a certain title or certain names does not mean that you're informed. It doesn't mean you're stupid either. It means that you're naive. So I think we all really have to work on cross-pollination.
The neurologist may be an expert in peripheral neuropathies from diabetes, but he's not really got any interest in the brain. They may be a specialist in spinal problems or unique, odd third world encephalopathies or something, but EEG may not be their thing.
Forte, I was teaching a workshop at this place once, and there were, I think, 4 or 5 neurologists, and I'm thinking, great, this adds to the conversation. So, we're talking about different cases where there's no epilepsy, but we can see spikes and this and that, and I'm talking about it, and I'm asking them questions, and they're not getting back to me. At this point, I'm getting a little nervous because I'm thinking, they're going to grill me because this glorified technician is talking about epileptiform discharges, and what does he know? So, when it's break time, the organizer approaches me, and he tells me, please stop asking the neurologist questions because they don't know what you're talking about. So I was making them look bad, essentially.
Mhm.
And they send a message, please stop asking questions.
Wow.
And, so
Did
I'm
you get
careful
rid of
about not, trying to sound medical. I will say I am trained to identify them, but I will always refer to a neurologist that I work with, so the neurologist can confirm or debunk and diagnose.
A neurologist that specializes or has applied knowledge in EEG
Correct.
or QEEG. So, I mean, and this way we also have to take some responsibility here. If we're bashing neurologists, how the heck are we going to get them on side? Okay. I think it's really, really important to, again, recognize what scope of knowledge is. And yeah, anybody who's teaching out there, see if you can't recruit the young ones. Unfortunately, neurotherapy isn't as lucrative as a lot of the other things. I mean, that's also an issue as well.
Our guy Radar wants to know, can somebody explain commission errors versus omission errors?
Sure.
Yeah.
The CPT task, a continuous performance task. Well, first of all, it's not continuous; it's episodic. But nevertheless, they're called a CPT.
Stop confusing people.
The CPT task, it gives you a stimuli that you're supposed to either respond to or not respond to. If you respond to something that you shouldn't have responded to, that's a commission error. If you skip something that you should have responded to, that's an omission error. And people that have inattentive ADD tend to be omission, tend to be hyperactive, then you have more commission, as a real simplification.
You can also go
do versus don't
lateralize
do.
there too. Issues of omission tend to be left hemisphere vigilance, precentral gyrus, beta, and issues of commission or lack of monitoring or impulsivity tend to be right hemisphere, precentral gyrus, or SMR. So you can kind of look at a classic go-no-go CPT like the IVA or the TOVA, and you can sort of map them to the QEEG, and that's why they fit so well and used together, I think. So
now you can do auditory integration training and help the auditory integration. If you've done an IVA that's auditory and visual, and you've seen both the auditory and visual performances aren't really up to snuff for attention, and you do the auditory integration training and the auditory scores get better, usually the visual scores get better. They may not have fully gotten okay, but they usually move along with the auditory improvement. And Ali got a fair amount of data collected on that, and I suggested he get it actually published. He's gotten it. It sits there, but it's good, solid data, pre and post with auditory integration training.
Triona Bateman asks, yes, we all need more education and training. What trainings do you suggest? That's a big matzo ball.
Well, start with going to Susan and AEPB and ISNR. Take Santiago's classes.
Well, I don't know where Triona is starting from, but I'm not going to tell her to go to any of those things to start with, because she'll walk away with her head in whirlwind of craziness. You need to find a good basic course to start with.
Yeah, I would say,
pick something and learn it. Don't confuse yourself by learning 12 different things all at the same time. Pick one thing, learn it well enough to feel somewhat comfortable with it before you decide to add anything else. But please start with the basics, because I don't care what your prior education brought to you. If you have not been educated in the brain and EEGs and everything else, start there.
Yeah, I would add the didactics are a good way to start. And to me, the key, at least personally, it's mentoring and supervision.
Yeah.
Find a good mentor or several mentors. It's always a good idea to get different points of view and different ways of doing things. You can do the group mentorings. Jay does group mentoring. I do group mentorings. Most of the people on our panel will do group mentorings or one-on-one mentoring sessions. I think that's very, very important. That's key to the learning, because you're working with somebody who's been in the trenches, who's seen things that you haven't. And again, it enriches the knowledge. And that's the point that I bring always when I do a workshop. Do mentoring. It doesn't have to be with me. There's plenty of people out there who are very good, very smart, smarter than I am, and they'll be happy to teach you what they know.
Dr. Hill, 80% of your business is remote. Dr. Hill, 80% of your business is remote. And this training question, the way I got trained was I dropped 20 grand on an amplifier and I go to a training 3 times. And anybody want to buy a used amplifier? What do you do rentals on your systems when you send them out? How does that work?
Yeah, usually. Yeah. Well, Peak Brain has something like 100 kits in our stable now. And we keep them pretty well occupied with people who are doing neurofeedback from home. And we have a smaller number of kits that do brain mapping, that do full head EEGs, because we only train 1 to 4 channels of EEG, plus we do HEG, passive infrared. So our amps are fairly small and low key for training. They're about $1,000 retail amps. So we can get away with using pretty low cost equipment for the neurofeedback. We still use Eager for our software, so there was some cost involved. But for EEGs, for QEEGs, we just use Cognionics devices, which are about the cheapest you can get. And they're tiny and don't weigh anything, which helps a lot with shipping. If I was trying to ship around a bunch of big bulky amps with giant batteries inside them, it gets dangerous and a lot of wear and tear and expense. So we send these little tiny deck of card size amps out, the camp, with a cap, and we do live guided recordings with our coaches running the software, gathering 20 minutes of EEG. And since it's done from home, people can do things like look at their caffeine or their cannabis or their pre-workout right there because they happen to be at home, so they can, really examine their Adderall. I can't go off caffeine for this EEG. Okay, you really should. And since it's so important to you, let's do a caffeinated one too, and show you what that looks like. And we can do that without any real cost, to the person, which really helps a lot with like this owning. I appreciate what you guys are saying about the lack of the DSM. I lean further away, and I want to just teach people to understand their own physiology. I want them to become the experts more than me getting to that answer for them. But I'm really hewing really away from clinical perspective, so to do that.
Well,
and
Dr.
I have a brilliant idea here, I think. Is there a list anywhere of who does group training and in what methods? Has anybody done that? Because I know
BCIA has blueprint stuff for people to learn how to become practitioners. But if you're looking at it as a parent coming in, that's a different level of education.
Oh no, I'm talking about those who wish to learn and practice, and not just with
within the certification bodies they do, but not outside of that. Like you can find lists of people or
they're mentors. I don't know whether there's a listing of group, and there's something really good about group. As I said, I know Jay does it, Santiago does it, I do it. Andrew and Anthony and Joy, do you do group mentoring?
I don't.
I do individual mentoring.
Yeah, me too.
Yeah.
I because I'm not clinically licensed, it's a little bit more dicey when I'm providing advice to somebody. So I tend to provide it at the individual level when they're very, very skilled, It's like just to circle back to the very first thing we talked about today, I'm getting referrals over the past 5 or 10 years, a lot more from psychiatrists. I know they're not neurologists, but 25 years ago, when I started in the field with Larry Hirschberg, his big complaint was, why aren't psychiatrists referring in? I'm working with all this autism and ADHD, childhood anxiety and seizures. Why are psychiatrists not my biggest referral source? Why are they just passing over completely? There's just no purchase there, no traction. Now I get psychiatrists that send me every single one of their clients when they get them, because they want to see the QEEG, they want to think about medication choices, they want to be careful with diagnostic language, because they've had the experience of me sending back QEEG showing no ADHD when they've been giving ADHD diagnoses and things, So I think psychiatrists are an undertapped resource for those of us who are neurofeedback people. Most of us, there's very, very few psychiatrists that do neurofeedback. But
a lot aren't interested even. But I think the other beautiful thing is the same thing going way back when, probably I'm going to go like 20, 15 years ago. The psychiatrist wouldn't know what this was, and you'd have to, the open ones, you'd have to explain to the skeptics, you'd have to write. And now, you know, when somebody comes and is like, hey, can you fill in my psychiatrist? You call up the psychiatrist, and they know what you're talking about. They're on board. It's a really, really nice change.
I have a lot of psychiatrists who send
titrate.
people to us, but I have a lot of psychiatrists who also just say, hey, I think neurofeedback's a good solution. Find somebody. Like, I'm getting that too.
That's
I'm getting
true,
both
yeah.
like, oh, peak brain, you know, but I'm also getting, oh, there's this thing for ADHD. If you don't have meds for your kids, oh yeah, neurofeedback should work. Find some of that. And then they Google and they find me, you know, so I get a lot of that indirect.
And they
like,
can find some people you don't want to find too. So you got to be careful. Due diligence.
Yeah.
All right.
Well,
My
given
experience
given
has
that
been
long-term medication can end up leading to long-term negative health consequence,
yeah.
methylphenidate taken for too many years ends up having a higher incidence of movement disorders, and so the psychiatrists end up having potential liability if they end up going to meds without considering alternatives that have a lower level of risk. And first to no harm is usually neurofeedback.
That's true.
All right, all. We're at time. I think we did a good job, Joy. What do you think? Feel better?
Well, there was no protocol development on the sidelines tonight, so I'm delighted.
I hear you. I just want to, slap me around. It's the only way I understand. Santiago, thanks for showing up. I know your arms are tired flying all over the world. And Jay, I know you're 75th, man. I know you rocked it out, and I know you got to get some Z's. Dr. Marie Swingle, thank you for showing up again. Dr. Hill and Anthony Ramos, thank you. Another great session.
The hurricane catcher.
Yeah.
No more. You guys can take them or something.
No, thank
really
you.
cool.
I'm going to be in a bunker next time. Yeah.
I'm moving to Arizona. All right, all.
Okay.
Have a
All
great
right.
week.
Thanks, everybody.